Okay, let's start over. Welcome again to this webinar for temporal lobe epilepsy provided by the CortiCare Continuing Education webinar series. Tonight's presentation is by Dr. Navita Kaushal, and she is definitely well qualified to provide this information to us. She is currently the LTM manager and continuing education coordinator for CortiCare, but previously she was a neurodiagnostic technologist at Einstein Medical Center in Philadelphia and an adjunct faculty member at Delaware Community College in Downingtown, Pennsylvania. From 2009 to 2012, she was a research professional associate in the Department of Pediatrics at the University of Chicago Medical Center. She received her BS and her MS from the Punjabi University in India and her PhD in physiology from the All India Institute of Medical Sciences in New Delhi. She completed her postdoctoral fellowships in the Department of Psychiatry at Harvard Medical School and the VA Medical Center in Brockton, Massachusetts, and the Department of Pediatrics, University of Louisville. Welcome, Dr. Kaushal, and I will now hand this off to you after making one announcement, and that is this is being recorded now, and after the conclusion of the webinar, you'll receive an email with a link to an evaluation form, which you need to complete and submit if you're going to receive asset CEUs. And following the webinar, if there's any questions, you can enter those into the chat area and we'll handle them as we can. Thank you again. Dr. Kaushal, it's all yours.
Hello, everyone. We had technical difficulty. It appears I was the only one talking and there was no audience here. So now we are back and I hope everyone can see the slides and can hear us. Hello from Pennsylvania. I'm going to talk about temporal lobe epilepsy today. I have nothing to disclose. All the materials that I'm using for this webinar are purely for educational purpose. I got these materials from the web, and some of the EEGs that I have are also from the web, and a few are from the patients monitored at CortiCare. And again, these EEGs are meant for educational purpose only. I'm going to talk about anatomy and the functions of the temporal lobe, different types of temporal lobe epilepsies, seizure semiology of temporal lobe seizures, EEG examples to show you the temporal lobe seizures, and there are 2 videos from International League Against Epilepsy to show you the semiology as well as the EEG during the temporal lobe seizure. And I'm going to talk a little bit about the failure and success of temporal lobe surgery. So temporal lobe, the lateral aspect of the brain, just inferior to the frontal lobe, separated from the frontal and the parietal lobe through with the lateral fissure or the Sylvian fissure, lateral sulcus. 3 gyri, 3 sulci on the lateral aspect of the temporal lobe. It's pretty simple structure when you look at it from the side, but as you go towards the mesial side, it kind of becomes more complicated. The mesial aspect of temporal lobe, the limbic system, comprises of thalamus, hypothalamus, amygdala, hippocampus. Out of these 2 structures, amygdala and hippocampus are part of the mesial temporal lobe. The major functions of these structures is in learning, memory, and regulation of emotions. The emotional responses like fear, anxiety, aggression, they come from amygdala, and long-term memory, decision-making reside in hippocampus. Apart from that, temporal lobe is a site of auditory and center for language. 40 plus Brodmann areas, and out of that, the major one in the temporal lobe are auditory association cortex, area 20 and 21. 22 is Wernicke's, that is the language processing center. The 28 and 34 is a hippocampus, which is again on the mesial side, inside the inner part of the temporal lobe. 37, occipitotemporal lobe, occipitotemporal area. 41 and 42 are the primary auditory cortex. So basically your language, your auditory cortex, they are the major components of the temporal lobe. I'm going to talk about hippocampus and amygdala, giving them special importance here because hippocampus, which comprises of pyramidal neurons, these neurons are highly excitatory and they are the major EEG generators. And they are the major cause behind the temporal lobe epilepsy. Hippocampus, it virtually translates seahorse. It looks like seahorse. So these neurons, the pyramidal neurons of the hippocampus, like I said, they are highly excitatory neurons, and they project towards the temporal neocortex. Any fault in these neurons, if there is absence of inhibitory signal in these neurons, since they are excitatory, so any damage to these neurons, they cause temporal lobe epilepsy. Another structure, amygdala, which is an integrative center for emotions and motivation. And this center receives signal from all the senses and from the visceral areas. If there is a damage to temporal lobe, any lesion in the temporal lobe stimulates amygdala. Stimulation of amygdala causes intense emotional response like aggression and fear. And we all know those are some of the auras people have when they have temporal lobe seizures or they have temporal lobe epilepsies. So stimulation of amygdala causes panic, causes the anxiety attacks, panic attacks. The PET scan shows people who have panic attacks, they have hyperperfusion of the parahippocampal gyrus. Same thing is seen with patients with temporal lobe epilepsy. Speech areas broca, which is part of the frontal lobe, responsible for speech production and articulation. The area in the temporal lobe Wernicke's, it's responsible for language processing, written and spoken language processing. And we all know people with dominant hemispheric temporal lobe epilepsy or temporal lobe seizures have fluent aphasia. The fibers which connect both Broca and Wernicke are called the arcuate fasciculus or arcuate fibers. Any disconnect between these two areas causes conduction aphasia, where the patient loses inability to repeat simple phrases. And if there is a damage to both the areas, it causes global aphasia, which we see in temporal lobe seizures too. If the seizure spreads to the frontal lobe, patient can show both fluent as well as expressive aphasia. There are two types of temporal lobe epilepsies. Temporal lobe epilepsy is a focal epilepsy. It is the most common form of medical refractory epilepsy. Almost 70% of the patients who got diagnosed with epilepsy have temporal lobe epilepsy. Again, it is a focal onset. There are two types, mesial temporal lobe epilepsy. Nowadays, the new name is coming up. It is also called limbic epilepsy, but we're going to stick with mesial temporal lobe epilepsy. It begins in hippocampus and the surrounding tissue of the hippocampus. The age is between 10 to 20 years. It is highly associated with febrile seizures, but not every kid who had febrile seizure will end up having temporal lobe epilepsy. Hippocampal sclerosis and medial temporal sclerosis are other causes for the temporal lobe epilepsy. Since 1825, physicians knew that people who had seizures, they had shrinkage of the hippocampus. I think the first paper was published in 1880 showing that the hippocampus is damaged, there is scarring of the hippocampus, but we still do not know if the scarring of the hippocampus is causing mesial temporal lobe epilepsy, or is it the epilepsy of epileptic tissue is causing scarring or the sclerosis of the hippocampus. That cause and effect still has to be established. The second type of temporal lobe epilepsy is lateral temporal lobe epilepsy, which involves the outer and the lateral part of the temporal lobe, basically the neocortex of the temporal lobe. Almost every single patient who has temporal lobe epilepsy, it starts with an aura. People have déjà vu, a feeling of familiarity, or jamais vu, where they have a feeling of unfamiliarity. A sudden sense of fear or panic. They may feel angry all of a sudden, they're aggressive, they're sad, or they are happy. Many patients also report a rising sick feeling in their stomach, like as if they are on top of the roller coaster. They have altered sense of hearing, sight, smell, taste, or touch. Temporal lobe seizures are categorized as focal aware or focal impaired seizures. So these are focal seizure, focal onset. According to the ILA classification, we used to call them simple partial seizures. That means the patient is aware during the seizure. And complex partial was the name we know as focal impaired seizures. So it means these focal seizures, the patient can present with loss of awareness, or they are completely aware. Some of the seizures, the patient is aware during the initial part of it, and during the seizure, during the actual electrographic changes, the patient has impaired consciousness. If the left temporal hemisphere is involved, patient has impaired consciousness and speech arrest. However, if the seizure is originating from the right temporal side, the speech is preserved and the consciousness is retained. We just discussed aura. Every temporal lobe seizure, almost every temporal lobe seizure starts with aura. Seizures begin with behavior arrest and steering. So this is quite a similarity with absence seizures, but absence seizures are generalized seizures and temporal lobe seizures are focal seizures. So we're going to talk a little bit later during this talk about the absence and the temporal lobe seizure. Automatism is another, it's basically the hallmark for temporal lobe seizures, right? A manual or complex motor behaviors. It's most of the time that automatism is confined around the mouth area, like chewing, swallowing, lip smacking, and hands, automatism of the hands, like they're picking something, they're looking for something, they are exploring. And they do not have recollection of this behavior. We do see automatism in the frontal lobe seizures too, but that automatism is like bicycling, paddling, so like large amplitude motor component in the frontal lobe seizures. But in temporal lobe, the automatism is confined to hands and to the mouth. Patient to feel confused, sense of fear and panic. They have butterflies in their stomach, and they may have unusual speech. They even lose the ability to speak and read and even comprehend and communicate. Some of the temporal lobe seizures, they evolve to generalized tonic-clonic. Almost every frontal lobe seizure evolved to generalized tonic-clonic, but some of the temporal lobe seizures, they do have motor manifestation. But it does not start as a motor manifestation. Later on, it becomes the larger components, the motor components get involved. Patient may have clonic, tonic, or versive movements, depending on what area of the cortex is involved. These seizures are for longer duration. They last up to 1 minute. Another big thing that separates these temporal lobe seizures is dystonia, dystonic posturing. It's the contralateral side of the dystonic limb. That's where the seizure is originating from. So I'm going to show you a picture here. So dystonic posturing of hand and arm, or even of the leg and foot, is seen. So here is a picture. There are two cases here. In the top here, patient has lower limb dystonia patient is diagnosed with right-sided hippocampal sclerosis, and if you see, there is left lower limb dystonia. In the second picture here, this patient in blue gown here, patient in the first picture, patient is eating. And in the second one, if you see, the right hand dystonia started to begin, and then it involves the right lower extremity. The leg kind of gets inverted. There's an internal rotation, flexion at the knee and the hip. So this is one side of the body is showing dystonia. And in the upper picture, it's just one limb, one lower extremity is having dystonia. And the seizure is on the contralateral side. I'm going to show you a video of temporal lobe seizure. If you can give me 1 second, I'm going to go to the video library. All right. I'm going to play this video here. I think it's not playing the video. Okay.
Yeah, we see it.
You can see it?
Yes.
Okay, I cannot see on my end. So would you let me know when it finishes?
It just finished.
Okay. All right. So in this video that you see, the patient is sleeping and they wake up. I'm just looking for my slides. They wake up and they have impaired awareness. There is right arm dystonia, and you can see ictal changes on the left side. I'm going to play the next video here. I'm going to go to the video and play video. Okay, Jeff, let me know once it's over.
Mm-hmm.
All right, the second video, it also shows the person is confused, and there is right arm dystonia. There is fearful expressions, and there were electrographic changes. So the right upper extremity dystonia and left hemispheric temporal lobe seizure. All right. Let's discuss about subtypes of temporal lobe seizure. The mesial temporal lobe and the hippocampal seizures are categorized as autonomic seizure. These are the seizures when the patient feels rising epigastric sensation. They have abdominal discomfort, belching, they feel tachycardiac, they may have difficulty breathing, and pupillary dilatation. Cognitive seizures, which originate from the mesial temporal lobe with a feeling of déjà vu and jamais vu. Patients do have emotional seizures where they have feeling of fear, panic, anxiety, and even feeling of doom. Sensory seizures are with unpleasant olfactory and gustatory sensation. All these seizures, they are focal seizures. Patients do have impaired awareness. There is behavioral arrest. However, the seizures which originate from the mesial temporal lobe and hippocampus, they do not evolve to bilateral tonic-clonic. These seizures are of longer duration compared to the lateral lobe seizures. And we do see automatism of the lips, the chewing, swallowing, tongue movements, and things like that. So mesial temporal lobe epilepsy is the highest form of epilepsy. So the seizure onset is not detectable by surface electrodes. So our 1020 system, it's hard to detect with that since the seizures are originating in the deeper areas. So that activity, that excitatory activity of the neurons has to transmit to the temporal neocortex for us to record that. Due to this reason, there is high prevalence of false lateralization of the temporal lobe seizures. Now, when the temporal lobe is unhealthy, it cannot produce enough electrical activity, but it can spread to the healthy neocortex. So that means even if these seizures are coming from the temporal lobe, from the deeper areas of the temporal lobe, they are not being projected correctly since the temporal lobe cortex is unhealthy. So it goes to other areas, the other parts of the neocortex picks it up. Anyhow, once the seizure originates, it can propagate to the ipsilateral temporal neocortex. It can move to contralateral hippocampus. The speed with which it moves to the other hippocampus. So only one hippocampus can seize, and the seizure can propagate to the other hippocampus faster than it can propagate to the ipsilateral side of the temporal lobe. And it can simultaneously, it can project to the ipsilateral neocortex and the contralateral side, contralateral hippocampus. So basically, you may have seizure originating in one hippocampus is projected to the entire temporal, to both the temporal lobes. The ictal patterns, they appear as focal discharges. Sometimes it's difficult to see a full-blown seizure when it originates from the deeper areas. So this is, once upon a time, we used to call it TERDA. We don't call that anymore. So this is generalized rhythmic delta activity, sharply contoured, and it is maximal at the temporal region. So this is the kind of EEG that we usually see in the seizures coming from the mesial temporal lobe. The neocortical temporal lobe seizures are again, they are focal seizures, so they are sensory auditory seizures. In the beginning, we talked about the auditory, the speech. That's what the lateral temporal lobe is all about. In these seizures, patients have they hear a basic sound, which is like buzzing or ringing, but it is not a formed speech. It's more of a psychic phenomena. That's why olden times people used to be embarrassed to talk about, because they cannot express the feelings they are having. They are having focal temporal lobe seizures, but they're not just able to explain because it's more of a psychic phenomena. Patient complaint of being in dreamy state. There is change in visual perception, and there are multimodal sensory hallucinations. Some patients feel vertigo, and there are some clonic movements. So evolution to focal to bilateral tonic-clonic seizure is a common thing in this. Now, if the seizure is originating from the temporal lobe, chances of it to spread to the frontal lobe or to the motor cortex is higher compared to the seizures which are coming from the deeper areas. However, these seizures are of shorter duration compared to the mesial lobe seizures. What does the EEG look like? So activity it's widely distributed, so you just cannot pinpoint that where it is coming from. There is a lack of clear lateralized discharges. Pre-ictally, there are occasionally sharp waves. And during the ictal phase, we see irregular polymorphic 2 to 5 Hz lateralized activity, mostly theta rhythms. Ipsilateral or contralateral spread to parasagittal region is also seen. So here is, you see the lateralized rhythmic delta activity with faster frequencies, spike and wave discharges at the temporal lobe. Here is another example of the temporal dominant intermittent rhythmic delta activity with faster frequencies. And at the bottom right here is a right temporal seizure. This is another example of the left temporal seizure in progress. This is 3 pages combined together. I'm going to go one by one. There's one slide here. You see there is paroxysmal fast activity at the left temporal, and there is built up at the temporal, and it is spreading to the left central. And here is a left temporal spreading to the left central area, and the seizure is ending with still remnants of some sharps and paroxysmal fast activity in the temporal region. Here are 2 images taken from this article here. This article does have 2 videos, actually. I did not bring up the videos here. In this first image, patients' clinical features were as if they are conducting an orchestra, basically. The arm is going up and down, and the EEG onset happened after the clinical presentation. So here it's the right side seizure with the left hand automatism. And if you look at the MRI image, which shows right temporal cortical malformation, and the SPECT scan shows hyperperfusion of the right temporal. The second image here, it shows left temporal onset seizure with the MRI, which shows enlargement in the left amygdala, and the PET scan at the bottom, this image F, PET scan shows left temporal hypometabolism. All right, this is another video of a focal seizure. I'm going to go to the videos to show you that.
So do we push her to the end of the month?
That's the day after Memorial Day, right?
Right. And so her equipment is supposed to come on the 6th, but it's the day after holiday. So
Jeff, is the video playing?
Into a Sean situation where Sean's equipment was supposed to come Thursday, come Friday, he still didn't have his docking station.
Yes, it is.
So I won't hold my breath it's going to get there Wednesday.
Yeah, we know.
So do we hold off on her until the end of the month?
How bad are the open shifts that do we need her?
All right, so in this video, the patient is fully awake. It's a right temporal seizure. Patient is awake, communicating with the staff. So since it's a non-dominant hemispheric seizure, the patient continued to converse, continued to discuss during the seizure. Contralateral region of the seizure is if there is unilateral sensory aura, hemifield visual aura, motor version, clonic activity or tonic activity of a limb, dystonic posturing. We saw the videos that projects that the seizure is from the contralateral side. Post-ictal palsy, eye deviation, and unilateral ictal paresis are the lateralizing signs of the contralateral side of the brain. What are the causes? What are the causes of temporal lobe epilepsy? 25% of the temporal lobe epilepsy's causes are unknown. And in other cases, it could be injury to the neurons of the temporal lobe, especially the mesial temporal sclerosis or hippocampal sclerosis. Somehow these areas are highly prone to neuronal injury and sclerosis, and even infections. Any abnormalities that are present at birth could be hematomas, malformation, or cortical dysplasia. Brain injury from accidents, fall, or blow to the head. Infection, abscess, meningitis, encephalitis, AIDS, stroke, tumor, AVM, and of course, genetic factors also play a role in temporal lobe epilepsy. There is there is a common underlying circuitry. The electrographic mechanisms of the temporal lobe absence seizures, they kind of overlap. So common semiology of these temporal lobe and absence seizure is there is alteration of the consciousness. Seizures start with steering. So basically, it's like a negative motor phenomenon, right? Motor arrest happens. And there is amnesia. Patients do not remember that they just had a seizure. Even if temporal lobe is a focal seizure, absence is, of course, a generalized seizure. So some common semiology, it makes it difficult to begin with to diagnose the patient. So the major differences between temporal and absence lobe seizures is that temporal lobe seizures are very long. They are compared to absence seizures. Absence seizures are anywhere between 4 or 5 seconds to 10 seconds, compared to the temporal lobe seizures, which last up to a minute. Temporal lobe seizures start at any age, but the absence seizures are usually start during childhood. Patients have aura. In absence seizures, there are no auras. Temporal lobe seizures are focal, whereas the absence seizures are generalized. With temporal lobe, we see focal abnormalities and generalized spike wave discharges during absence seizures. Automatism, a hallmark of temporal lobe seizure, which is not there in absence seizures. Patients do have post-ictal confusion, but in absence seizures, there is no post-ictal confusion. However, they both do not remember the events of the seizure. There are similarities between frontal and temporal lobe seizures. These mesial temporal area and orbitofrontal cortex of the frontal lobe, they are in very close proximity. So the seizures, they share some sort of similar, some similarities between them, right? We require neuroimaging, intracranial EEG to confirm if the seizures are extratemporal, if the epileptogenic zone is outside temporal lobe. Olfactory hallucinations, which are present in both this type of seizures, but the temporal lobe, however, has wide range of auras. But one of the hallucination or aura which kind of confuses is the olfactory one. In frontal lobe, in temporal lobe, we see oral alimentary automatism. And hypermotor automatism is in the frontal lobe seizure due to presence of involvement of motor cortex. And you see just hand automatism in temporal lobe. Temporal lobe seizures are of longer duration compared to the frontal lobe. And the frontal lobe seizure, mostly we will see expressive aphasia compared to the receptive aphasia in the temporal lobe seizure. Now, if that seizure spread to frontal lobe, the patient may have global aphasia. This is some of the differential seizure semiology of the temporal and the frontal lobe. Like the seizure frequency, frontal lobe seizures are, there's so many. People get they get it often, daily. Seizure onset is slower and abrupt with temporal, and the progression is slower, but in the frontal lobe, it is a rapid progression of the seizure. We see automatism in temporal lobe. The steering, motionlessness is more in temporal compared to frontal. Complex posturing, which is less frequent, it appears later in the temporal lobe seizure. But in frontal lobe, the posturing is very frequent. As soon as the seizure starts, you will see the posturing, the change in the posture in the patient. Frontal lobe are hypermotor seizure. They have bipedal automatism. Somatosensory is common in frontal lobe seizure. The vocalization is very different between temporal and the frontal lobe. So frontal lobe is more of a grunting, screaming, and moaning kind of a noise. But vocalization, if the non-dominant, so speech impairment, if it's a dominant, and it's a different kind of a scenario when a non-dominant hemisphere is involved. Secondary generalization is less common in temporal lobe, but with the frontal, most of the frontal lobe seizures do generalize into do evolve into generalized tonic-clonic seizure. The drugs of choice for the temporal lobe epilepsy are lamotrigine, Keppra, carbamazepine, oxcarbazepine. Okay, so, but still, there are about 40% patients who are on anti-epileptic meds with temporal lobe epilepsy still develop refractory temporal lobe epilepsy. And the only solution that is left is the surgery. Surgery has a high success rate. Temporal lobe epilepsy surgery has high success rate. It's because the areas involved in the temporal lobe epilepsy, they are well-defined areas, and there is not much variation from patient to patient, because we know either it is hippocampus or amygdala. So those are the areas which are the seizure generators in temporal lobe epilepsy. And it's easy to target those areas. Once epileptogenic zone is defined, it's easy to remove that, to do the surgery. And the success rate is somewhere between 2 to 10 years. Patients are seizure-free, and 80 to 90% of the patients show less and less seizures, or absolutely no seizures after the surgery. So different types of temporal lobe surgeries. One is anterior temporal lobectomy, where they resect the lateral temporal and some parts of the mesial temporal structure. So of course, the idea is to identify the epileptogenic zone and remove that. Another surgery is anteromedial temporal resection. So the anterior part of the temporal lobe is resected. And once that part is resected, they access the mesial temporal areas like uncus, amygdala, hippocampus, and parahippocampal. Amygdalohippocampectomy is done through the fissure. So they do not remove the anterior part of the temporal lobe. Through the lateral fissure, they access amygdala and hippocampus, and either through laser ablation, they remove those areas without touching, without damaging, without removing the anterior temporal lobe. Temporal disconnection. If the patient's epilepsy is due to non-lesions on the temporal lobe, they disconnect the temporal lobe from the frontal, from the parietal, and from the occipital. So basically, they're separating it so that the seizures can be controlled. Stereotactic ablation, neurostimulation is just for palliative thing in temporal lobe epilepsy. It's not going to cure the patient. And new techniques like anterior thalamic stimulation, hippocampal stimulation, and cortical stimulation are the techniques which are coming up to control temporal lobe epilepsy surgery. The idea is to have minimum side effects after the surgery. So newer techniques are coming up. So here is a table which shows the deficits patients have after temporal lobe epilepsy surgery. So the biggest of the deficit that they have, one is a memory deficit, the visual loss. It's usually partial. Many cases like partial hemianopia in 46% of the patient was seen. Then some nerve palsy. Very few patients show motor deficits and cranial nerve palsies. So there are still complications with temporal lobe epilepsy surgery depending on how they are approaching the epileptogenic zone and how much of the tissue is being removed. Now, why do epilepsy surgery fail? There are still 10 to 15% of the patients who will still have seizures. So the one reason could be there is an insufficient resection of the epileptogenic zone from the mesial temporal structures. So maybe they did not remove the entire tissue which was causing the seizures. There is insufficient on resection of temporal neocortex. They were not able to fully detect the epileptogenic zone in the neocortex. And maybe there is dual pathology. It's not just temporal lobe that is causing the temporal lobe seizures. It could be some tumors, some infarcts, or maybe cortical dysplasia that is still causing the seizures even after removing resecting part of the temporal lobe. And in some patients, they have seen that contralateral temporal lobe relapses. So even if there was no epileptogenic zone to begin with on the contralateral temporal lobe, and after the surgery, somehow that tissue becomes epileptogenic. There are other areas where the ictal zone resides. It could be the frontal or the parietal lobe, or the occipital lobe, the opercular region, the region which the three lobes that meet, temporal, parietal, and the frontal lobe, they meet. Maybe the epileptogenic zone was sitting there. That could be another reason for patients to relapse. And the epileptogenic zone could be in the insula, the fifth lobe. And after removing the temporal lobe, maybe not just the neocortex, but the mesial components too, a patient still shows seizures. So these are some of the reasons that temporal lobe epilepsy surgery fails, but this is the most successful epilepsy surgery to control seizures. Different resources used to make this presentation. I'll take any questions if you have.
And if you have a question, please type it into the chat area now, and we'll address it. And we'll give ourselves a couple of minutes here for you to enter those in. One thing I'll ask, I'm assuming that in many cases in working up patients that may have suspected temporal lobe epilepsy, that using higher density EEG, or in the old days, I know that we attempted nasopharyngeal EEG electrode placement. Is that still done?
Yes, some places they are still done. Those electrodes are usually placed by the MDs. They go through the nose and they record from the mesial aspect of the temporal lobe.
And now I'm sure that in some patients they're using stereotactic depth electrodes in order to assess that, especially if you're looking at the hippocampal area.
Correct. So the hippocampus, you just cannot access it with the nasal electrode and the 1020. So the only thing that is left is to do the depth recordings. And those depth recordings are done on both hippocampi. You just cannot think that, okay, the patient is having left temporal lobe seizure, we will record only from the left. Sometimes the epileptogenic zone is one hippocampus, but the seizures will appear in the another hippocampus because it would propagate quickly to the another lobe, to the another hippocampus, and then the seizure will be projected in a contralateral lobe. So when they do depth recordings for hippocampus, they record from both hippocampi.
Very good. There is one question that we've had which has to do with aura and whether or not you can have aura frequently maybe, but it doesn't necessarily progress to a seizure.
Correct. So the auras are just a feeling that the patient gets. It may not evolve into a full-fledged seizure. That's why some of the temporal lobe seizures are just a psychic phenomena, then having electrographic changes, a clinical kind of a thing that you would see. They will stop at aura only. And if that feeling, quote unquote feeling, it happens multiple times a day, it is worth investigating. It could be the seizures that are coming from maybe from the amygdala or from the hippocampus, maybe part of the hippocampus, if not the entire hippocampus.
Very good. There is also a question about, again, temporal lobe seizures evolving into generalized seizures. Is that common or not common?
No, it's not common. It's rare. Again, it depends on the symptomatic zone, like how much the excitatory neurons, how much of that electrical activity spreads. So if it spreads from hippocampus to the lateral temporal lobe, and from there, if it is very close to the motor cortex, then of course it will go to the frontal lobe, and it can become a generalized tonic-clonic seizure. But most of the temporal lobe seizure remain focal, and they do not evolve to be generalized. But I'm not going to say they never evolve to be generalized.
Very good. Well, that's all the time we have. I want to thank you again for an excellent presentation. And everyone, there will be another one coming up next month. So look forward to the invitation. Thank you again, and good night.
Good night, everyone.